Good morning, everybody. I think we're ready to get started. Others will be logging in slowly as we progress, but we can go ahead and get started on our case for the day. This is our seventh case conference, I guess. Seventh? Yeah, seventh case conference. And here we go with Sherlock Holmes. And we're going to be talking about KB, who's a 66-year-old male who his primary care doc is here in South Tampa, and he had some bizarre chest pain, several kinds. And so he said, well, I need some understanding of what's causing this. And so he was sent over here in August 2015, about 8 months ago. And the pain, he had described a couple different kinds of pain. One kind was sort of constant, 4/10, and then it would increase to 6. And he had a location in his chest, something in his back, some shortness of breath, very difficult to sort out. He had occasional palpitations, but he didn't have PND or pedal edema. But he did have some risk factors that would make this make a lot of sense. He had some hypertension, type 2 diabetes, a nice systolic murmur that we'll find in the physical exam, and he was on medicine for his diabetes, including Novolog, Metformin, Levemir. He also had Victorza. He was also on cholesterol treatment for elevated cholesterol and hypertension treatment. Had multiple allergies. He is still a smoker, 56 years of smoking and continuing to smoke. No special diet. Overweight. Had a prior workup of a stress test and an echo, both of which we don't have. Everyone seems to have had a stress test and an echo sometime. Everyone seems to have had a nuclear scan sometime. His BMI is 34.7. Blood pressure was controlled. Had a systolic murmur that sounded like aortic stenosis. And that was pretty much the findings. 2+ pulses. And what to do next. And Pooh, would you like to make some comments on what you would do next in this gentleman?
Sure, chest pain, so EKG.
There you go, Pooh. Go ahead. There's your EKG. Tell us a little bit about that.
So normal sinus rates about 65 or so. Let's see, axis is going leftward, and then R wave progression. Let's see. Actually, there's early transition, but there's no like late transition to make me think, oh, it's anterior MI or something. No, these very outstanding.
Okay, it looks pretty good. It looks like they're maybe borderline first-degree AV block or first-degree AV block. Not sure about that. It's hard to measure right here, but it could be. And then his echo showed, we don't have that to show, but he had, or do we? Do we have his echo to show? Oh, we have a second echo. We don't have the early echo. It's gone to PACS and storage and lost in the internet ether space somewhere, but he has an ejection fraction of 69% with normal contractility. His hypertension hasn't been exactly well controlled because he has mild LVH, which would be about a thickness of 13, and that would be a measurement of the control of his hypertension if he didn't have aortic stenosis. So he does have aortic stenosis, so it may tell you more about the aortic stenosis than the hypertension. So he does have a moderate stenosis, which is about a 30 millimeter peak systolic gradient across his aortic valve, which appears to be bicuspid, has a little calcium. And then like everybody else this age with these risk factors, he's got some non-obstructive calcified and non-calcified left common carotid plaque, usually in the bulb, and normal hemodynamics. And so where do we go from here in evaluating this bizarre chest pain in this gentleman? Pooh?
So lipids we can test, obviously. This PULS test, I've seen you get it. I don't know if you've got it in this case. CTA, kind of to see where we are as regards the coronary anatomy, how does the valve look, and kind of take it from there.
So let's take a look and see where we go. Well, as everyone knows, I don't sell the six-pack, which is history and physical, EKG, echo, SPEC, and cath, which actually SPEC scan, I had somebody who was in one of the hospitals, I think it was in Brandon, and the doctor called me and said, patient had chest pain, we're going to do a SPEC and cath, which means they don't even know what the results of the SPEC scan is, and they're already considering doing a cardiac cath because it's a SPEC and cath. We did find out from the SPARC, S-P-A-R-C study that doctors don't act on the information. That is, the test has such low credibility that the results were not important in determining the next step on taking care of the patient. That was a whole big research study headed by Dr. DeCarli in Boston at Brigham called the SPARC study. We expected to find out, we were trying to find out if PET scanning was best or SPEC scanning was best or CT was best. And what we found out is nobody looks at any of it. They just go ahead to the next step. And so that was kind of interesting and revealing. So as you know from listening to me, that Blue Cross Blue Shield and 47 hospitals in Michigan determined that even though everyone says that their SPEC scan is good and others aren't so great because they can read around the artifact, they found out in those 47 hospitals there's a 40% false positive, 65% false negative. At Memorial, we have a 50% false positive, 50% false negative, not much different from flipping a coin. One of the universities is 80% false positive. I was asked not to reveal the name of the university because they didn't want people to hear that. Ottawa, Canada, 9 hospitals, 88% false positive. So this test, is a fail. And so we have to all own up to it, admit it's a fail. We're not reading around the artifact. The breast gets in the way on females, the stomach gets in the way on males, and it's a total fail. Although the insurance companies have your actuarial tables, and they're not admitting that. And so we've gone on. We have admitted it's a fail. Actually, they're paying a lot less. It's down to like $500 now instead of $1,367. And so we're looking at low-cost, high-value. We're transitioning into the value age of value imaging. The CMS is saying that they're going to be value 90% of cases, not fee-for-service, by 2018. And so value imaging is the name of the game. Also, in terms of training fellows, COCATS, which is the Committee for Cardiovascular Training Standards, basically are saying that we have to have CT and MRI embedded in our training programs, that we have a 4-wheel Ferrari rather than a 2-wheel Ducati. So it's not just echo and nuke. We have in cardiovascular non-invasive imaging at our fingertips, CT, MRI, nuke, and echo. So we've got to be moving in that direction. So we are moving in that direction. That's the purpose of this conference, is actually to show you the application of CT, MRI and how that can become embedded in our practice, and try to embed that in the 16 hospitals of West Florida HCA. So moving on with that concept, and as you see here in this meta-analysis, 64-slice CT has a high sensitivity specificity, and MRI imaging has the next highest sensitivity and specificity, and basically blows away all the rest of the stuff down the line. And so that's why the technology is becoming obsolete. So we did do some CT images, and we're going to show them to you. Hang on right now, and we'll get this up. The overread was interstitial lung disease, not surprising in a smoker.
Hey, Dr. Harrison, this is Malika from Bennett Point.
Hi, how are you? Yes, I can hear you.
Okay, great, because we're trying to, because for some reason I was able to go into just a listen-only mode, but I guess you can hear me now, so that's great. Thank you.
Oh, this is where Mindy is. I hear you loud and clear, loud and clear. We're going to be having I think we're going to have dinner with one of the program directors, Dr. Pino.
Uh-huh.
We have a dinner coming up with him next week.
Oh, that's great.
So we're going to take you to our images, and so here's a 4D volume rendered image of our gentleman. And just looking superficially and externally, we see that he's got a very small right coronary artery. We could call that hypoplastic. And so the right coronary artery is going to be very little interest to us. We can see that the LED does have some plaque here. We'll have to identify it in more detail. The volume rendered image isn't the best for understanding the detail inside the artery. You can see it's a bumpy artery. Look at the lumps and bumps. These are calcified plaques that have been paved over like cement and pushed out to keep the channel open. Man, you couldn't do any better than to cement it over with calcium to render it inert and then push it out and keep the channel open. That's amazing that nature has a way of doing that. There's some calcium up here too, and then we can look at the circumflex, some stuff in there that we can look at externally in a dominant circumflex circulation, giving off the posterior descending, which is in the interventricular groove inferiorly, coming off from the circumflex itself. So let's look at some more detail on this patient. So we'll go to the axial image, and here's our axial image. No surprise if you see aortic valve calcification, since we know it's supposedly a bicuspid aortic valve functionally. I can't tell looking for this because it's distorted. There looks like 3 different things, but one could be just a raphe, which is an incompletely formed commissure. And we see a lot of calcification in there. So this is consistent with our 30 millimeter gradient across the aortic valve that we found. And so we can look at the left ventricle, and we can look at the papillary muscle. We can measure the thickness of the left ventricle. We can go over here, and we can drop a line at the level of the junction of the cord with the papillary muscle, looking at the posterior wall. And as we said, it's borderline LVH, and voila, 12.7 qualifies for borderline LVH. And so it looks like this is falling into place just like we expected to. We don't see any infarcts. We don't see any thinning. We don't see the apex is normally thin, so that's no surprise. Apical thinning is characteristic of the left ventricle. Mitral valve is here, right ventricle, right atrium, interatrial septum, and this all looks pretty good. Left atrial is not enlarged. We can drop a line and give you a measurement somewhat perpendicular there. It's a borderline. You can, with people with chest pain, you can rule out pulmonary emboli. You can also look at the aorta and rule out dissected aorta. You have enough information here. And so it's a triple rule out. And then we go to coronary artery disease. There's that little hypoplastic right coronary coming off up here. And so let's go look at these coronaries in a little more detail. So we get our volume rendered image up here. We're going to show some vessels. We're going to get this out of the way. And here we are with our coronary artery. This is the left anterior descending, sometimes referred to as a widowmaker if you have disease in it. So you see a lot of calcification of the origin of the main left artery. There's a bifurcation up here, so this becomes the LAD. There's calcium in there. There's a diagonal vessel coming off the side over here. Where you see this little blue line is where we have the blue box, is where we have the blue dot. So you can follow this longitudinally as well as cross-sectionally as well as 3D. So now let's color code this a little bit because that makes it a little more pretty and makes the information a little more graspable quickly. And so we can color code it according to Hounsfield units, which is density. You can see the calcium is coded yellow. The lumen and contrast is coded green. Necrotic core is coded red. And fibrosis is coded blue. And so this is what we're seeing here. We can move down this vessel and see what we see. And we're coming into some red zone. We're coming into some narrowing and then expanding again. So this would become what I would call a plaque of interest. So we have a plaque of interest. We'd like to know more about it. And so there's a little indentation there. We can put this up here and get some information about that plaque. And so that's where the branch is coming off just above it. So it's going to get narrower. There's a branch up there somewhere. Oh, that's the branch up there. Okay. So this is a plaque of interest. And so let's take a look at this plaque and look at it in many cross sections and spread them across here. And so I'm concerned about a plaque like this when I see it because the necrotic core is 48% in the total plaque, as well as the plaque isn't a significant blockage, but it is a blockage that's might be called intermediate or moderate. We can move this marker down here. Obviously, it's like in the 50% diameter range. It has to be 85% diameter to be significant, and so we're a long way from having a significant lesion. It does look like there's a little convergent divergent double cone in there, and a lot of necrotic core. And for the whole plaque, it's 48%. For this one area that we're spotlighting and looking at of the plaque, 56.8% of it is necrotic core. So I'm worried about this, and I'll call this a plaque of interest. And if there's somebody that we're going to follow up on, this would be the one that we would look at this particular plaque in the future to see what's happening to it. But unfortunately, we can't really predict which plaque is going to rupture. It looks like maybe it has to do with positive remodeling, and that's a factor for rupture. Also, spotty calcification in non-calcified plaque wall is also for rupture, and then things we can't measure like thin fibrous cap can be responsible for rupture as well. And that's a cap that's like 65 micrometers, which we can't get close to that, as opposed to 85 micrometers, which won't rupture, and that's called thick. So 85 is thick, 65 is thin, and we can't measure either one of these with this or IVUS, but we can with something called OCT. And so that's optical coherence tomography, And so we do use that in the cath lab some. So I've looked at the other arteries here. Let's go over to the circ, because the right is inconsequential since it's such a small hypoplastic vessel. Circ looks pretty good on what we're looking at here, as opposed to the volume rendered image where it didn't look so hot. And we have another circ vessel here, so let's go look at that one. And here's the other circ vessel, an OM1. And that doesn't look too bad. We have some narrowing, which we can see right in here. We have some necrotic core, but it doesn't reach my standards and what I'm really looking for. So it's not a strong plaque of interest. It is a plaque of interest. So this is the information we had. I don't see anything that's going to give this guy any kind of angina. I'm thinking his chest pain has nothing to do with pulmonary emboli, nothing to do with dissecting aorta, and nothing to do with coronary artery disease. So we got a triple rule out of this gentleman, which was very helpful in evaluating his chest pain, although he sure has a lot of coronary disease, and we did pop up with a plaque of interest. So let's go back to our PowerPoint presentation and move on. Okay, so next slide just is showing the same point. And I want you to look at the calcification, the yellow. I want you to see this little area here, like a little elbow, that we didn't really pay much attention to. But we're going to look back at it soon as we go forward. We're going to look back at this and compare it to what we see later. And then the plaque of interest, which was down here. So when I have a plaque of interest, I usually am involved in finding out more about that plaque. You can have a 50% diameter stenosis and actually be underestimating it and still have a reduced distal FFR. And so that's why we need to measure FFR or measure something functional or something to do with flow. And so you can also have somebody who's high risk who basically has inflammatory markers. And those are the things we're concerned about. So Pooh, what would I suggest doing at this point, since you know how we practice here?
CTFFR.
So we're not doing FFR because that wasn't available to us at the time, and so we did do a Lexiscan stress MRI. I'm sorry I can't show this image to you because we've had so much fun looking at those together, and I apologize for not having the image up, but it wasn't unavailable at the time. But when we injected the gadolinium and watched the distribution in the myocardium, basically it was homogeneous, and so we didn't find any areas of decreased myocardial perfusion, nor did we find on late gadolinium enhancement any areas of scar tissue. We could see the aortic stenosis. We could measure using something that we have that we can basically figure out the velocity of blood. We can actually measure just like you do with a Doppler and tell you from phase exactly what the gradient is across the aortic valve, which again we came up with about 35. And so that's the information we got from this test. And so we're feeling pretty good about this guy. And we also did the test that we call the pulse test. And on the pulse test, that's where you use these inflammatory markers, which have to do with apoptosis and also have to do with cell migration. And so you get more familiar with this as we look at this as part of our research studies. But we have interleukin-16, we have hepatic growth factor, we have FAST ligand and SFAST, both of which are associated with up and down on apoptosis. The rest of them are cell migration. So basically, he had 2.53 higher risk for an acute cardiac event than expected for a 66-year-old male, basically with his risk factors. And so that's interesting, but it's not high. And the ones we've seen cardiac events with have been 5 to 6 times normal. So I'm reassured about this as well. So I'm feeling more confident now. The validity of the pulse test from NIH multi-ethnic group as well as the Marshfield Clinic. And this is how this form is published. When we get this in the mail, this is what it shows us. And I'm interested in the ratio, which is 2.53. And so further testing, I think we've just about done it, and so we're not doing any further testing. We're going to put him on some medical therapy, which is continuing anti-cholesterol medication and then trying to moderate his lifestyle, and that's very difficult with smoking cessation, regular exercise, and Mediterranean diet. That's a big lifestyle change that you're going to see when we look at his body surface area 8 months from now and we look at his BMI and so forth. You'll see there's no change because it's very difficult to change any one of these 3 habits. So in the interim, patient continues to have intermittent chest pain and back pain. However, he feels better about it. You know, he's reassured. He reports he's taking his medications, exercising regular basis, taking his medications, has a little increase in his hepatic enzymes that he's had all along, not much to confirm stopping the medication. It's just maybe a little bit above normal, maybe 20-30%. But there's always a big but on a case presentation. He appears one day after Super Bowl Sunday on what he called Super Bowl Monday. He had severe chest pain while he was sitting, left arm pain, back pain. He was sitting around drinking his coffee, nothing going on around him. He's so blasé. He came in 3 days later to see us. And so what would you do now, Pooh?
Another EKG to see if he had the event.
And there you go. See what you think about this one.
No Q waves that I'm seeing. 2, 3 ABF, even. There are no real Q waves I'm seeing to kind of predict an event. ST segments look okay, so pretty similar to the last one, pretty unremarkable.
Yeah, I don't see any change, and so that's we've got an echo. So let's look at our echo. So Pooh, if you could tell us a little bit about this echo, we'll sort of try to row you through it. And nothing's moving. Just a second. Hang on here. There, it's moving. Okay.
Again, we see the LVH. that we talked about.
Okay.
I mean, at least in parasternal lung, the walls seem to be coming, the posterior walls coming in, anteroseptal maybe. I mean, I need more views to say for sure.
So we'll keep rolling through this for you, Pooh, as you call out what you see. Of course, the calcified aortic valve, the LVH she's mentioned, and of course, we're looking for wall motion abnormality in somebody who had chest pain.
If I can see the short axis, that will be the quick and dirty.
So these things are really slow when we show them. They're slow loading, they're slow moving. Or we'll give you some more images.
Septal and lateral wall. Septals coming in. Laterals coming in too. I'm more interested in the anterior wall because we've seen the LAD plaque to see if that.
Hey, that's very good that you're keyed into our plaque of interest, and you're using that knowledge as we move on. So that's a quantum leap in terms of connectivity of bet cells and dendrites.
This is okay. Do we have a two-chamber or the short axis?
Sorry we can't make this thing move for you a little better, but basically, as it turns out, that the wall motion is all normal, and so the cardiology roundtable and the advisory group basically has said that this is a good test to rule out acute coronary insufficiency, as it turns out that less than 1% of people with acute coronary insufficiency will have a normal study. And actually, I've only found 2. And even of those 2, you can still figure out what's going on, because one has classical chest pain, angina, and the other one has a markedly abnormal EKG. So I think this is foolproof. It's better than the highly sensitive troponin, because you get, all those positives with highly sensitive troponin, where this you only have positive if there's something really going on. So it's a very useful test, front-loading the echo in the emergency room. We're even thinking about getting a V-scan where we train the ER docs and have them look at themselves and record in the trenches, in the ER, with a handheld device. So front-load echo, very useful. And so this guy basically has a less than 1% chance of having acute coronary insufficiency. And so we all feel very happy about that. But what happened to him? What was the cause of his chest pain? What else would you do, Pooh?
I mean, we could get a follow-up CT to see if it changed. It could be plaque rupture, plaque embolized down below. It was like a transient blockade, and then it kind of eased off, and the plaque went distally versus dissection, PE, all that's a possibility too.
So we've got the opportunity to do our triple rule out again, and also find out what's happening to our unfriendly plaque as well as our friendly plaques. We're going to get these images up for you. Hang on. Okay, so we processed this case for a triple rule out, and so up here we look at the aorta, looking for a dissection, our rupture, negatory. We can look at the aorta, another view, and then in a third view. That's okay. We see the aortic calcification that we saw before because of the known aortic stenosis. Left ventricle looks fine. Don't see any area of the left ventricle that's abnormal. You can't see edema in this particular kind of study. We could do after the dye injection, you could do a delayed 10-minute image and see if there's any contrast that's left in the wall. That's a way of telling more about the wall of the ventricle. But let's move on to the coronaries because that's our area of interest here. So no pulmonary emboli, no dissection, and now we want to know about these coronaries and what these look like. Let's get these guys up, and let's get some color on here. And let's get some images up. And then let's scroll down. So the plaque of interest was down here. That doesn't look like there's any change. And actually that's what a lot of people say in the literature, that the plaque that ruptures is not the plaque that we saw, but a different plaque. And so let's go see if there's change in a different plaque. And aha, we have an area here just after that bifurcation. There's a vessel that came off just above there, right there. There's this notch where that elbow was that we identified before. The elbow now is filled with necrotic core and narrowed. There's a narrowing there. And so there's been a drastic change in one plaque in the last 8 months. Now there's no date. Unfortunately, they don't date these things, and there's no date put on here. So we can't tell you exactly when that happened. We can see the calcification, and the calcification makes the vessel look like it's occluded, but it's not. That's a beam hardening that makes it look that way. And then we can drive up to this one little area, and we can see that there's narrowing in there that wasn't there before, and there's a lot of necrotic core that wasn't there before, like 51% in that particular area, and the entire plaque is like 30% volume of necrotic core. And so this is a new deal in this patient, a new evident plaque that has new complexity to it. So let's go back to our PowerPoint, and here's the picture that we took of that, and we can compare that to the previous picture. Isn't that pretty? Wow, look what happened to the elbow. Looks like the funny bone got bumped, and so the elbow has got this big hole in it now. And there's the big hole, and it looks like there is indentation, there's remodeling. This whole thing just kind of went into it. Now, to cause the chest pain would be more than just a rupture. You'd have to get some platelet clumps on here, and then the platelet clumps would have to either obscure the vessel and block it off, and then basically lyse again and be okay. Or you could get spasm on top of that because of the irritation, or you could get embolization causing the chest pain. So here we are, normal wall motion, so therefore not acute coronary insufficiency, but ruptured plaque, and things have changed in his coronary anatomy. And how do we know this is an acute rupture? Well, we just have saying that because of the chest pain. Perhaps we can do other things to find out more. So what to do next? Who?
More studies on the plaque, FFR, more to the last one. Obviously, we'll continue medical therapy and lifestyle, but I'll do more studies on the plaque.
So medical therapy. So we decided to load Plavix, 600 milligrams of Plavix, just like the patient, if he'd shown up in the ER, we'll be taking him to the cath lab. If he had a real occlusion, which he doesn't have, we're going to give him the same amount of Plavix we would normally get, which is a loading dose of 600 milligrams. That's 8 tablets with 75 milligrams daily. There's a new drug called Voraxapar. Basically, that's Zontivity, and that also has been shown to be useful in peripheral vascular disease, acute coronary syndromes, and acute myocardial infarctions. It's an additional platelet inhibitor drug that shows added value in terms of reducing risk. And then we actually said, hey, let's stop the simvastatin. Let's go to the biggest cannon we have in terms of dropping cholesterol, and that would be Crestor, although PCSK9 may also be a big one in terms of giving subcutaneous injections. We went right to the Crestar and continuous home medications. Maybe we got his attention this time. We did order some lab tests. Ordered a troponin, NT-proBNP. The reason why we targeted the NT-proBNP is the BNP itself is a 22-minute half-life. And so if it was Super Bowl Monday, then the patient showed up on Wednesday, then the BNP would be back to normal if it had a little blip. And so we ordered the NT-proBNP, which has a much longer half-life. We decided to repeat the pulse test stat. I don't think anybody's ever ordered one of those stats. But we ordered one stat and sent it to San Francisco and actually to Irvine, California for testing at Global Biosciences that has a lab there. And then we looked at a metabolic imaging test and actually ordered that for yesterday to see if the plaque was metabolically active and to see if it lit up when we give sugar, because if it's very active as an inflammatory lesion, it should take up F18 and into the cell and then keep it there, and it won't come back out. It gets stuck in there, and then the radiation comes out, and we make pictures with the positrons as they annihilate with electrons and give off gamma rays. And so we said, let's do that and see if we can see a hot plaque there. So unfortunately, we don't have that test because his wife now had maybe sympathetic chest pain, and so he took her to the ER and was unavailable for testing yesterday. And so we can look and see what one of these looks like. And here's an aorta that's got a bunch of stuff in it that's lit up. That's the descending aorta. And then here's the left anterior descending that has a lot of calcification, and it's lit up quite a bit here. You know, and the other things are, there's some incidental findings over here in terms of the aorta. And so aortic plaque, coronary plaque, descending aortic plaque, and brown fat white will light up too, and so there perhaps there's some brown fat in here that's lighting up. And so that's very nice, and this would be a good test if we can, and we'll show it at a future conference because it's unavailable. So we're talking about the natural history of coronary plaques. That's interesting because we all read about it in the textbooks, but we don't have any direct experience. This is a way to gain some direct experience, beneficial to the patient as well, and we'll demonstrate that to you. Let's talk about processes first. What's going on here? If we were going to do a calcium score, we would just be measuring the calcified plaque. Well, calcified plaque is not very important to me. It certainly may be the tip of the iceberg, and calcified plaque is not very interesting because it's plaque that's been neutralized. It's been cemented over, pushed out, positive remodeling, and so I'm not interested in that. I'm interested in the vulnerable plaque like the necrotic core, fibrofatty, and so if you were going to add up all the plaque, you'd have to add up to get total plaque volume or burden. You'd have to get the calcium, you'd have to get the fibrous, you'd have to get the fibrofatty and necrotic, and add all that together. You're not going to be able to do that with calcium, with a calcium score. Calcium is just going to be a part of that. Well, you see what's happening here is an equation that's being driven from left to right. Necrotic core, fibrofatty, fibrous, and dense calcium. And basically, when we get to the right, we've pretty much got a neutral platform here with a 9% chance of all plaques that rupture. 9% of them are dense calcium that eroded through the endothelium. And so that's a low number when we're talking about coronary artery disease. And so these are pretty benign things. If you have one focal calcified plaque or two focal calcified plaques with positive remodeling, chances of having a heart attack are less than 1%. If you have total normal arteries, you have a 15-year warranty. Can't beat this information. Statins accelerate this transition. You probably always wondered what statins do. Well, they're anti-inflammatory for one, and so that's very helpful in lowering our pulse score. But the other thing that's helpful is it accelerates this process, driving this equation faster from left to right. Sometimes all plaques go to dense calcium and the process is over. And somebody had a period in their life when they probably had some stress, they had some high blood pressure, they had some inflammation in their coronaries, and it all resolved and got normal. Other times, there are new plaques that are being formed, and it's a continuous process driving from left to right, but feeding into the right side with continued substrate. And so we have some people that do that over a period of a year, 2 years, every 3 years, get more inflammation, and they have to come back and get stented every 2 or 3 years. And they're pretty much regulars. We can count on, I know a patient we can count on 3 years from now in November, he'll be coming back no matter what we do. We're trying other things on those patients now. We're trying anti-inflammatory agents. We're using colchicine to see if we can change that, because we've seen the process go on in several patients, and we want to make a change and see if that will interrupt this process. Other people are using methotrexate to try to change that process. And so we can look at all this stuff: serial characterization, inflammatory markers, total plaque burden, predictability of calcium score in predicting ACS, and how can we get more images that we can compare? And actually, one of the things we do is, you know, that retrospective imaging is a thing of the past because of 11 millisieverts of radiation exposure, but step and shoot with prospective imaging is less than 3 millisieverts, especially if you add iDose and iterative reconstruction. And then in addition to that, we have the capability of doing a 1 gantry rotation to give us less than 1 millisievert, frequently 0.5 millisieverts of radiation exposure with 1 gantry rotation to produce an image of a plaque of interest. Of course, that's going to give us radiation that's very low, the same as a dental x-ray. So we're really getting low. We're getting CT scans that are equivalent to 2 mammograms. Some people with model-based iterative reconstruction are getting images that are equivalent to 2 chest x-rays. We hope to move to that platform next as we upgrade our equipment. And so we're interested in no plaque, no worry, minimal calcification, low risk, and then the other plaques and what they fall into and how we can work with them. And so plaque rupture is exactly the name of the game here, and that's where theorizing that happened in this patient. But we can show you other plaques, and look at the difference in this plaque. This plaque basically got bigger, so that's called remodeling. Okay, the wall has been pushed out. The lumen got smaller. Okay, that's called increased stenosis. But we have less of the necrotic core, that's the red stuff, and we have more of the fibrosis, which is the blue stuff, as the plaque transitions to being calcified and pushed out. And so this is probably a good result, you know, in terms of it's less dangerous. It could be an angina-causing lesion now, whereas before you were at risk of sudden death or a heart attack. And so not a very good choice, sudden death or a heart attack. So necrotic core at the stenosis site has gone from 38% to 7.2%. Necrotic core in the entire plaque has gone to 44 to 22%. Dimer stenosis has increased from 40% to 63%. The cross-sectional area increased from 60 to 80%. And that's what we see here. So we predicted by reading the plaque that this patient was going to have angina at maximal exertion. You can see over here the convergent divergent double cone that we're always looking for, the rocket nozzle type physiology in terms of computational fluid dynamics. And so we predicted at maximal exercise. Patient was sitting next to us as we were reviewing this. His doctor was next to us too. And he said, how did you know that? That when I'm on the treadmill, I'm now getting some discomfort at maximal exercise. How did you know that? We knew that because form follows function. Remember, form follows function. And so here's another patient that is a young guy. He's 31 years old, and he's got this linear thing that's heavily dense, that looks like calcium, that you say, that looks like a staple. I mean, it's so homogeneous, so well organized. And we were wondering, well, what's going to happen to this over time? Is this dangerous? Is this pretty stable? Is there some continuous process that's going on? And we really weren't sure. And why would he have a single plaque like that at age 31? And so without having any kind of known hyperlipidemia situation. So we did wait till he's 33. You can see this is just a piece of his heart. It's just the top part. We just made a picture of the top. Single gantry mutation, creating what we call the placogram, less than 1 millisievert of radiation in a 31-year-old guy. That's good. And we follow up, and it looks identical, no change. We think this is actually was from a percussion wave of some sort. We don't think this is atherosclerosis. It just doesn't read like. Look, it's on the wrong side. Usually we see this on the diagonal side of the LED, and in this case it's on the septal perforator side. The patient has a very bizarre EKG. We're wondering if he actually lost some septal perforators there, and that's why he has the abnormal EKG. And so this was useful in this patient because you said, stable, no change in 2 years, go about your business, have a good day. This is another guy who basically can't take statins. Maybe he's a candidate for PCSK9. I don't know. Those are injections that you give subcutaneous. He can't tolerate statins. Like apparently 40 to 50% of people can't tolerate statins. That's huge. That was shown in the studies of PCSK9. The drug companies never showed that when they did their statin studies. I wonder why. And so we see a diameter stenosis in this particular plaque of 56 to 55%. So that's a plaque of interest, And so actually, these are two plaques that were measured separate times, 3 years apart, and let's see what the difference is. Well, you can see it looks different. Actually, it looks like the lumen got bigger. It looks like there's still some red stuff scattered around, still some blue stuff, but let's see what we got when we ran the numbers. And the numbers show that at the highest area of stenosis, that the necrotic core went from 31.7% to 33.8%. Not much change. Diameter stenosis went from 56% to 55%. That would be considered no change too. But the total plaque necrotic core over this total piece that we're looking at went from 34% to 26%. The fibrosis went from 46 to 33. Why did the fibrosis go down if the total plaque necrotic core went down? Well, everything went into calcification. And so we doubled the amount of calcification in that particular plaque, which is a good thing. So we think that we're going from left to right in that formula. We don't think we're adding anything in terms of new substrate. So we think we've got a stable plaque that's advancing into calcification, which is a good thing. 25-pound weight loss, 65 minutes a day, walking uphill. The plaque pulse test was 1.22 times normal. Hemoglobin AC dropped from 6 to 5.2. So this guy was very much encouraged by looking at these pictures. If you're knocking yourself out every day, doing 65 minutes of exercise on a treadmill going uphill, you'd like to have some positive feedback from somebody. And so seeing this was dramatic for him and knowing he's doing the right thing. And so that's just giving you some examples of some of the plaques we've seen, how we're using this technology, and how it's helping. So we'll throw the group open to any questions you might have at this time, because we're reaching the hour. Pooh, do you have any questions about this process?
No, sounds pretty interesting. That's a good thing to follow up on.
Have you seen anybody doing this anywhere?
No, not really. Is it like calcium score? Sometimes they say you can follow up, but is there like inter-observer variability? Like if I see or you see, or since it's so quantitative, we'll both come to the same conclusion. Does it vary from who's reading it or not? Not much.
Yeah, could you repeat your question in one simple sentence?
Sure. Is there any inter-observer variability? Like if two different people say this test, this person goes to some other city and gets it. Is there inter-observer variability as to the percentages?
Oh, that's interesting. Yeah, I don't know what's considered normal in terms of plaque progression from left to right. I don't know what's considered normal, and so I can't answer that question, but maybe as we gather more data and maybe as we get other centers involved in this technology, maybe we can get that information and we'll have a baseline of normals and then we can compare what's happening. But we do know that calcium score increases over time And we do know that with statins, calcium score increases over time. And people say, well, gee, that's terrible. His calcium score is going up. He has greater risk of heart disease. But actually, it's not a terrible thing. He's basically consolidating the plaque into something that's neutral that has less chance of rupture. So that ends it today, and I thank everybody for attending. We will be posting this on a website, and we will make sure that we get this posted. The website is going to be cardiaccarecritique.com. We haven't posted anything yet in the way of videos, but we will be posting all of them soon if anybody wants to go back and show this to a friend or see these videos again. Thank you so much for your attendance, and I'll say goodbye to Janet and Christine, Donna, Mindy, Pooh, Sharon. Melody's already signed off. Bye-bye. Thank you.